Absolutely. I think what it's done for pain psychology is it's really afforded us an opportunity to bring forward what we know is helpful. We have a lot of empirical evidence that shows what we teach patients when they use it, it helps. And that has really expanded that spotlight to physical therapy and pain psychology so that we can help patients to look at non-pharmacological strategies if they're interested in learning to manage their pain differently. In the medical school, or even in the medical model, that biomedical model, providers are taught from that they're the expert, the patient comes in, so they are delivering a message. That's not per se patient-centered communication. Patient-centered communication is really hearing what the patient has to say, validating their experience, being curious about their experience, their expectations, their beliefs, their fears, and really eliciting all of the responses. It's interesting to think about in communication. I read an article this morning that said that providers have a tendency to interrupt patients within 11 seconds of them starting to talk. And when they actually engage in asking them what they want, they interrupt them 7 out of 10 times. So that would not be patient-centered communication. With that study that I just mentioned, what was interesting is when the provider allowed the patient to just say what they wanted to say, they could do it within 6 seconds. So I think sometimes we interrupt because we have that time pressure. I don't think it comes from providers not caring. I believe that we get into the helping professional because we truly want to make a difference. But we have these time constraints, we have our own level of burnout that's contributing to it, insurance, the organization that we work for. There's no doubt that that is part of the problem. And if we allow patients to speak, they can usually get to it a lot quicker than we think they can.
I'd say it's been a mix. We get a lot of angry folks coming to see us, but it's an opportunity for us as well to educate them. And I like to incorporate some of the pain neuroscience education to help them understand what exercise is going to actually do to their brain and to how they're processing a pain experience. And we can break down some fears about different avoidance strategies they've had to try to avoid the experience of pain by avoiding activity. We can re-educate around that and then talk about all the endogenous opioid systems, all the things that they have access to in their internal drug control pharmacy that's in their brain and in their body, that they have the power to kind of unlock and use those resources. And we know that the things that we produce on our own are more powerful than anything that man has figured out how to make so far. And so it's really an opportunity to teach them and kind of change their perceptions and really move them towards an exercise as medicine philosophy. And if we can kind of change the way that we're behaving and change those things that we get into, those bad habits and those avoidance strategies, then we can really impact that and change the pain experience altogether.